nonprofit Steward Health Care system's swift unraveling and bankruptcy threw a grenade into its community hospital system in Massachusetts, last week announcing that while it had qualified bidders to take over 5 of its hospitals, it plans to close 2 others, the Kearney Hospital in Dorchester and Neshoba Valley Medical Center in Ayer. Officials across the state are decrying the move, with Governor Maura Healey placing the blame squarely on Steward's greed, saying the state has limited options when it comes to the Kearney and Neshoba without qualified bids. Meanwhile, Boston Mayor Michelle Wu has pledged to fight any attempt to rezone the Kearney site for any use other than a medical center. At the same time, lawmakers had the opportunity during this last session to move the ball on several major bills that would impact the healthcare system generally and situations like and including stewards specifically. They did so to a limited extent. I'm Jennifer Smith, and this is the Codcast, CommonWealth Beacon's podcast about policy and civic life here in Massachusetts. I spoke this week to Paul Hattis of the Lown Institute and John McDonough of the Harvard T.H. Chan School of Public Health. We talked as the system moved toward agreement on the sale of these 5 community hospitals. So, let's dive in. We are talking about this on Thursday afternoon, so we're going to be talking about some things that haven't yet happened but are expected to, and some things that have been unfolding over the course of many, many months. Paul, why don't you start out by basically running through the various parties that we've been keeping tabs on throughout this process?
Sure, Jen, happy to do that. Let me talk about who right now seems to have a direct interest and role in happening with the Steward bankruptcy in the formal process. Obviously, the people of Massachusetts and others are not in court there, but they're concerned too. But the direct parties include Steward itself, ultimately the hospitals who are potentially the purchasers of the Steward hospitals that are going to be sold at this point, the Steward physician group called Stewardship Health, lenders and financiers, which include both short-term lenders to Steward just in this bankruptcy era process, but longer-term lenders tied to the building and lands in the state, and of course our state government.
Perfect. So let's run through where all of those stand right now as we're talking before we sort of lay the groundwork going forward.
Well, for Steward, of course, this is their bankruptcy proceeding. Their goal, when all is said and done, is to get hospital assets, physician group assets, any other assets they have sold to pay creditors, because that's what the bankruptcy court expects. And at the end of the day, when that's all been identified and sold and probably they're been released from debts, they stand under Chapter 11 as a Steward operating company, and what their future is at that point, nobody knows. Now let's talk about what's probably of great interest for a lot of our listeners and the subject of what's happening right now, which is there are 7 Steward hospitals in the state. We know it's already been announced that 2 are planned for closure, Kearney and Neshoba Valley. That leaves 5 others that right now are under the opportunity to be sold, and there's negotiation discussions going on for those sale. The bankruptcy court has established that in the judge's mind, that ought to be completed by tomorrow. Again, we're sitting here Thursday afternoon. Tomorrow is Friday, August 9th, and that's the intent as far as that goes. There's also been this past week, we were told at the bankruptcy proceeding earlier in the week, that there's negotiations by at least 2 parties going on over Stewardship Health, the physician group, and by next Tuesday's court date, we might well have an announced successful bidder for who's going to be buying that physician group, both nationally, including in our state of Massachusetts. There's been some action this week on the lender and finance side. I think a lot of folks know that the complexity of the sales is that while Steward has owned the operating licenses for our hospitals, the actual real property has been owned by a joint venture between a real estate investment trust, MPT, and an Australian investment company, Macquarie, and they were supported by a mortgagor, the Apollo Group. Just this past week, and this was really directly to help make the negotiations happen in an easier fashion because they were getting bogged down, MPT and Macquarie have basically agreed to sell their interest in the land and buildings for Massachusetts only to Apollo. And, there's some discussions going on even today in MPT's earnings call that they report on about some of the financial aspects of that. I won't get into that now, but that means now in the negotiations right now include just Apollo Group on the financial side, along with the hospitals and Steward in those negotiations. Finally, the state government's involved. As we all know, the state on our behalf has been very worried about access to care, particularly on the hospital side. And they so worried, in fact, that they decided and offered and actually agreed to advance as much as $30 million to Steward to help the hospitals, the 5 of them that are still up for sale, have sufficient funds to even make it through the end of August on an operating basis. And what was decided last week is a little over $11 million of those dollars are actually going out in a check tomorrow. The rest of it, a little bit over $18 million, will only go out if, in fact, those transactions of sale are concluded, again, with a deadline by tomorrow in the state's agreement. So the rest of the amount to make up the $30 million would go out next week if, in fact, purchase agreements are achieved.
So I'm glad you brought up the state-specific money that is going to almost certainly go out tomorrow, because we are dealing with 3 buckets here looking into the future. We've got things that are almost certain to happen, things that we're pretty sure are going to happen, so likely categories, and then there's a huge suite of unknowns that still exists. So why don't we start off with perhaps the most concrete element here? What are we relatively sure is going to happen over the next days or weeks, Paul?
Okay, so tomorrow, an $11 million check will be written by the state. And at next Tuesday, if in fact between now and Tuesday, although the deadline supposedly is tomorrow, by court agreement, they could let it ride into the weekend, let's say. But by Tuesday court session, that judge is expecting completed sales purchase agreements for all of the 5 Massachusetts hospitals. If that's accomplished, because that means the parties have all come to terms, including for the real estate, the operational license, etc., then the Massachusetts will write the other check of a little bit over $18 million. Okay, that's the initial $30 million. They have also talked about future support for the hospitals, because even if we can make these transactions happen, those hospitals are going to need help from the state in order to make it financially. And the figure that's been in the media there is that over the next 3 years, at a minimum, it's anticipated that between the state putting up $35 million through a Medicaid-related mechanism and matched by a $45 million payment by the federal government for a total of $80 million, that $80 million will be available over the next 3 years to support those new hospital operators and taking over these formerly Steward hospital properties.
So then let's wade into slightly less certain territory. What is likely to happen in the near future? These sort of not full unknowns, not entire mysteries, but there's some moving parts that you can keep an eye on and sort of get a sense of what is likely to unfold in the next few weeks or so.
Well, there is an issue about Kearney and Neshoba and related timing issues, and I know my colleague John McDonough has a lot of detailed thoughts on that. So in a moment, I'm going to pivot to him to talk about that. But let me just mention unknown. One of the things that we're all wondering about over the course even of this weekend is, with Apollo now at the table, will they actually sell the land to the bidders? And I'll say, because it's been written about that publicly, it does seem that the bidders are nonprofit hospitals in our state, and on that list would include Lawrence General, Boston Medical Center, South Coast, and Lifespan, soon to become the Brown University Medical System of Rhode Island. So those are the ones that have been in the rumor mill as potential, purchasers, and whether some of them will end up actually buying the property if those transactions are finalized, or releasing it. In other words, a new lease agreement, that's an unknown at this point.
Can I ask either of you, whichever feels more comfortable kind of tackling it, on the subject of the bidders? There's been a lot of discussion in recent weeks, but also even recent days, about just how interested different parties were in taking on these hospitals. The question about whether or not the closures or the proposed closures of Kearney and Neshoba were because there were not suitable bids for that. So who wants to explain to me why the governor was saying there were qualified bids for all of these hospitals, and who wants to handle why it seems like that wasn't the case? John, you want to take a crack?
Well, I'll start with the two that are on the verge of closing, it appears: Kearney Hospital in Dorchester and Neshoba Valley in Ayer. And according to the state, there were no bidders for either of those facilities. And Secretary of Health and Human Services Kate Walsh was quoted in the Globe as saying, quote, "The market has spoken," unquote, which I think is an unfortunate phrasing for how to deal with this. But those were the words. And so basically the state has said there's nothing we can do. And so we're going to let those two close. And it looks like it will happen at the end of the month. The state Department of Public Health requires 120 days, and it looks like they are not going to agree to that. There's not a lot that the state can do to stop them. So there's a lot of concern in Dorchester and in the greater Ayer community. People are having public meetings, are protesting. The unions, the mass nurses, and the service employees have been getting involved in this and speaking out. The Boston City Council has passed a resolution there asking for an emergency takeover of the Kearney Hospital. So there's a lot of action on this. And in particular, by the way, there was one thing that came across just a few days ago in the Dorchester Reporter has a column by Bill Walczak, who I think many people know. He was the founding executive director of the Codman Square Health Center, candidate for mayor. He actually served a really short stint as the CEO of Kearney Hospital under Steward's ownership, and that didn't work out. He has a marvelous, wonderful history in the Dorchester Reporter of Kearney Hospital that talks about its history, its critical role in the community, its involvement in primary care and establishing a whole network of neighborhood health centers that really, I think, I think would give everyone pause in terms of looking at this and saying, man, do we really want to be the generation that just throws this resource to the side? So there's a lot of action there, but there's no sense at all at this point that the state is going to move and expose itself more financially to taking over these things when there's not even an owner in sight.
Thanks for that, John. I'm just going to add a slight tweak. One is that actually, in a technical sense, there was at least one buyer that came forward to want to buy. I think it was both Kearney and Neshoba. It was a small physician group who was actually bought a few other hospitals, a for-profit group of docs in Michigan, but they were deemed unqualified bidders by Steward, and so that discussion didn't go forward. The other thing is the state is holding a hearing this Tuesday in Dorchester tied to the Kearney, and this Thursday, upcoming Thursday in Ayer about Neshoba, to give, I think, the public an opportunity to weigh in a little bit on those specific hospital closures.
And I would add just one other small note in this ongoing drama, which is the angel of Apollo Global Management, which has bought the rights to the land and property, or is in the process of doing so, from MPT and its Australian partner. Lest people get too excited about a white angel coming in to rescue, Apollo is the second largest private equity company in the United States. It has had difficulty. The U.S. Senate Budget Committee recently accused Apollo of degrading care and operational quality through service cuts, layoffs, and other actions at the 220 hospitals that it operates in 36 states. So I think it might be a little premature to have a celebration parade for Apollo at this point until we learn a lot more about them.
And exactly to that point, John, because we're going to be talking about the legislature's role in all of this in just a moment, I wonder if you could talk about what seems to be the underlying question there, which is, to what extent are you clear of or not clear of private equity in this entire mess? To what extent is it going to stay kind of a major part of the Massachusetts healthcare system? Not going to make either of you break out a crystal ball on that, but how have you thought about what this Stewart saga so far has told us about either the reliance on or kind of the shying away from private equity in this space?
I'll tackle that. There is a belief from folks who are national experts on private equity at PitchBook and other places that basically, the private equity world has kind of given up on acute care hospitals. There haven't been any significant new purchases since about 2018. And the word I get is that they're kind of done with that. It's been too much of a headache and too many problems. And so if the dissolution of Steward goes the way it's going, where it goes to, part to Boston Medical Center or part to Seacoast, which, by the way, I believe is a for-profit and not a nonprofit, but a respected, locally based one, or particularly Lawrence General up in the Northeast, we see then the dissolution of private equity depending upon what happens to the land and the buildings. And so we could be seeing the eclipse of private equity's short-term and disastrous foray into the Massachusetts health environment, which I think that would be worth a parade.
And Paul, we've talked about the land itself, the cost of managing the hospitals themselves. I wonder if I could get you to tell me a little bit, what's going on with the doctors in all of this? Where's the staffing question coming in?
Well, for the listening audience, people might remember that before Steward even declared bankruptcy, they were going to be selling the physician group they call Stewardship Health to Optum. That ultimately didn't go forward when Optum pulled themselves out of the bidding process. But the docs in Stewardship Health are a combination of some who are employed by Steward, but some who are also own their own private practices and contract for managed care contracts through Steward. So in some ways, that is the most valuable asset within the Steward healthcare system, because those managed care contracts often do generate excess dollars beyond just the care costs for, in essence, who owns them. So I think what I've heard is that there's at least two bidders. I believe for-profit bidders. I don't know much more than that, and we should know more by this next week. Now, technically, the Health Policy Commission, it would be true for the hospitals as well as the physician group, but I expect if these hospital sales are announced soon, just to get the deals done, the HPC and our AG would likely be reluctant to want to slow down those sales because time is sort of the essence. With the physician group, it's a different matter, because once the hospitals are sold, I think there might want to be a clear-eyed look at who the buyer is, the terms, because one of the things to worry about is, could the physician group ultimately be bought by someone who in some ways makes the future life of the Steward or even some of our other smaller nonprofit hospitals in the state more threatened than they even are now. So I think, again, we shall see who the buyer is. We shall see ultimately what the review process, because it will have to go through the HPC in terms of a material change notice. So we'll see how the HPC and or the AG ultimately decide whether it's worth studying in detail, and if so, whether they support the purchase or not. Of course, I do want to add this note that if by chance the purchaser of the physician group were a company like a pure private equity firm, for example, it would not necessarily be subject to the HPC notice and therefore would escape state review by that process.
And while all of this is happening, we have been plotting, hurdling, tumbling, marching toward what has been described by many as a rather ignominious end to this 18-month, 2-year legislative cycle. And there were a lot of important healthcare matters that were on the table, along with a good dozen extra, also very important bills, not all of which were dealt with right at the end. I guess let's just start with what actually did make it over the finish line that had to do with the healthcare system after the smoke cleared at 9 a.m. on what was, through procedural magic, actually July 31st. So, John, you want to take us away? What did get done?
Well, so some things did get done, and important to particular groups and people, and not broad scale like some of the things that did not happen. So there was an expansion of connector care, a special category of health coverage for disadvantaged folks through the connector that got in through the fiscal year budget. There was a law passed that prevents copays for preventive services in case the Supreme Court tosses out the part of the ACA that protects those services now. Passage of parental rights to IVF for LGBTQ families, and stricter gun regulations. So there were some things that happened, and they are dwarfed by the lengthy list of things that did not happen.
Okay, you get to tee your own self up there. What did not get done?
So a major effort at health market, hospital market oversight that passed in the House and the Senate. Very different mechanisms to do it. So both sides wanted to do something, but had very different ways to do it. In particular, the Senate bill set up through the Mass Health Policy Commission a new process for health system planning, which I think we can look at the chaos of the last years or a couple of decades and say, thank goodness, it's about time. But that has been stuck, and that's not happening. Changes to the Mass Health Policy Commission's benchmark. So all of those have been kind of undone. Lowering prescription drug costs, long-term care reform, a bill that Paul and I highlighted about a year ago, the health equity legislation put forward by the Health Equity Compact, with a lot of support and energy, just kind of not happening. The economic development bill that didn't happen had provisions to license foreign trained physicians, which would help with the physician shortage. Substance use disorder, overdose prevention centers, maternal health, death with dignity. It's a lot on the cutting room floor that didn't make it. And the legislative leaders are saying they want to come back. They are not supposed to do that according to their own standards, but they can if they want to. But can they come back and actually get how many of these things done? And of course, it's not just the healthcare agenda. There are environmental bills on climate change, economic development. There are all kinds of other issues. So how are they going to prioritize this? And I think that people really kind of look at this and suggest that there's some serious dysfunction in our great and general court in terms of its process and in terms of the culture of how it's working and operating. So maybe some of us are looking forward to the initiative of the state auditor that would allow her to do auditing and other kind of oversight of how the legislature actually functions, not what it does, but how it functions and how it operates, because there's a need for some accountability that seems to not exist from any other quarter, not just on healthcare, but on the broader policy environment in the state.
And if I could get you, Paul, to dig in a little bit on what this seems to indicate in terms of their appetite to do anything about Steward. There were a few elements of what they were dealing with that would have at least somewhat implications as to kind of how the Steward proceedings would unfold. So what's your read on this?
Both branches of the legislature seem to have continuing worries about private equity and wanted to bring much greater transparency to not only private equity, but the kinds of organizations, entities that can own healthcare, whether it's real estate investment trusts or other investment firms and the like, to make sure that we have full financials, especially when ownership is out of state. I think that was an important focus of what they were trying to do, more transparency and then accountability. And I would add to John's really good list, there's also, we were hoping to see something to make people that have wheelchairs that can't get them fixed, some help to those folks, because that industry is dominated really by private equity owners. And I think both the House and the Senate did want to do something around pharma, whether particularly on some of the oversight accountability issues, although they didn't completely agree, or some of the out-of-pocket cost issues for folks. Having said all this, and I'm disappointed, I think, like my colleague John is, about a number of those provisions going forward. The one thing I will say, though, is in my mind, a bad healthcare bill would have been worse than our current situation of no healthcare bill. So what would have been a bad healthcare bill had some of the ideas, especially coming from the House, gone forward about making the HPC no longer under a conflict of interest provision, so that industry insiders could actually sit on the board and make decisions about parties and transactions that come through. There was going to be a multi-year benchmark review process potentially. Again, I had some trouble with the House bill where the HPC might have to sit on its hands for 3-4 years, even though a provider was having significant growth in its revenues above the benchmark. They wouldn't be able to do anything until this 3+ year period elapsed when the data was all in. And finally, I think both branches, the House and the Senate, want to help our lower priced or lower resourced hospitals. There's been stuff in the media about how price variation and its challenges still exist. The issue, though, is whether you do that just by throwing more money. In some cases, this would have been additional private premium money for that the House was suggesting, or private payment money towards some of those, without any expectation that those who are overpaid share in the cost of that. And that's obviously something that I've been very worried about and have written about. So I think there are some differences there, and we'll see whether the House and Senate can come together and come into agreement on some of those issues, hopefully in a way that I'm suggesting wouldn't make me say this was a bad bill when all is said and done. So.
Well, very much to that point, a lot of the delays and the logjams that we've seen over the course of this legislative session have been in part because there's been some pretty serious disagreement, not just in the substance of bills between the House and the Senate, but also there have been personality clashes, there have been disputes over rules and committee structures and assignments. So kind of looking ahead, because it does seem to me that the steward system process has been rife with red flags throughout, where perhaps someone could have stepped in or noticed some warning signs. What are both of you hoping for? And I think we'll leave it on this note. What are both of you hoping for as kind of this next step process happens from either the legislature itself in terms of specific action, or are you looking for the governor or other state bodies to kind of step in a specific way to try and at least cushion the blow once we've found ourselves in this situation to begin with? So, Paul, you were just talking, so why don't we start with John?
So I am particularly interested in the revival, reemergence, reinstatement of health system planning. I think that it is just terrible that we can hear the Secretary of Health and Human Services say the market has spoken and that's sufficient. There needs to be a state plan that says, here are our values, here's what matters to us, and here's what we need to try to preserve, protect, and defend in terms of what really matters. So I agree with Paul completely. We need a better system to help the lower financed hospitals, particularly places like Lawrence General that do such fabulous work with so little in resources compared to all of their gargantuan competitors. I'm very disappointed that with all of the energy put into the Mass Health Equity Compact, that nothing at this point that we can see has come. In terms of the legislative body, I think other places have done things in recognition to their incredibly effective advocacy. So those are some of my headlines. I could go on and on, but I'll stop there.
I agree with everything that John has offered, but I'll just make an overarching comment and tie Steward to the challenge of healthcare legislation or the role of government. We have a system, I think, unfortunately evolved where we have haves and have-nots. And Steward was a have-not system, and they inherited that situation when they even took over Corpus Christi. Somehow, as a state, and with better health planning, as John suggested, we need not only an allocation of resources, geographically, but an allocation or called reallocation of resources between all the haves and have-nots, so that no matter who you are and where you live in the state, or whether you're a Medicaid recipient or you have the most gilded commercial insurance plan, you can access the providers you need for your care, and they're near you and around you to do so, and the institutions serving you are adequately resourced. So I think somehow through state government, its oversight, what the legislature does, what the agencies do, we sort of have to even things out a little bit more between the haves and have-nots, and I think that would both be not only for a better functioning healthcare system, but more equitable, as John mentioned, the equity issues, and better for our folks overall, health status-wise.
Thanks again to Paul Hattis and John McDonough for joining me on the Codcast. Thank you for listening. I'm Jennifer Smith. Our producer is John Gee. Leave us a rating and review wherever you're hearing this now if you want to help other people find us, and email codcast@commonwealthbeacon.org if you ever want to get in touch directly. We'll be back in your ears next week.